inviting myself along, and good evening to everybody who's online this evening. So I'm Vitry Bucknail and I'm one of the other consultants at the Alder Hospital in Liverpool. And I understand that last night you had some teaching on lateral condyle fracture. So I've been asked tonight to stray away from what I was going to teach you, but actually to give you an informative lecture on non-accidental injury. And in fact, this could potentially save more lives than anything else that we're discussing this evening. So we're going to be having a little look at a case that I've come across recently, and then how you suspect non-accidental injury in a child, and then what you should be doing next. So I'm going to give you a little story just to set the scene as to what's going on. So I had a patient recently, a 1-month-old little boy, and he came in to A&E at Alder, and he was called Alfie, let's call him. And Mum came in as her first child. She was really concerned, really worried that he wasn't moving the left leg. And Mum seemed really upset by this. And she gives a story that he rolled off of a nappy changer, which is something that's, 3-4 foot high up in the air. And these were his x-rays that we got in accident emergency, and it obviously shows a fracture to the left femur. So we asked ourselves a number of questions during that consultation. And these are really important questions to always have in the back of your mind whenever you're seeing any child at all. And it's, does the energy fit with the mechanism of the injury? Is it possible that what they're telling us could actually cause this injury? And do we keep getting that story over and over again? Are they consistent with that story? We ask ourselves, did the child come straight away, or was it several hours or several days before the child came? And what does the relationship look like with the mother and the child, or the father and the child? And is there anything else that's worrying you? So these are things that should always go in the back of your mind. Now, with this child, if you remember, Alfie is only 1 month of age, so he's only 1 month old. He's far too young to have rolled off of a changer himself. So that makes us worry. Now, it's important that whenever we're seeing children, we have at the back of our mind, what are the normal ages for child development? I mean, we only need to really remember a few things here. So at 3 months, the child's able to hold their head up. At 6 months, they can roll. By 12 months, you'll be able to crawl. And by 18 months, we should be able to walk. And if the story is different to this, if we're being told that they've rolled off that changer at 1 month of age, well, that doesn't really fit with child development. So what we did next was we admitted that child. So the first thing to do is admit the child to a place of safety. And that place of safety is your hospital. You look after that child and you admit them. The next thing we did was we informed the child protection team. I'm sure there's a team like that in each of your hospitals. And we told the parents that we were doing this. We then did a secondary survey looking for any other evidence of injury to that child before starting treatment. Now, the story goes on a little bit more with this child in that whilst we were in accident emergency, we did another look at the kid, and Mum just seemed really upset. And then Dad arrives, and there's a big argument between Mum and Dad, and it actually transpires that Dad has been abusing Mum, and at home during an argument, Dad grabbed that child and pulled him towards him. So the child, like we say, was admitted, the fracture was treated, and we got those social services input. And for Alfie, he got better, and that was the end of the story. But that's not the case for all children, and there can be some really sad results of this, which is why we're having this talk tonight. So the first thing to say is, what is child abuse? Well, child abuse is something that either directly or indirectly causes harm to the child. And that harm could be anything from a delay in their development, it can be physical injury, or even in its worst case, it can be death. And abuse, unfortunately, takes lots of different forms. We have emotional abuse, making the child feel worthless. We have neglect, which is a failure to provide for that child, either with thirst, hunger, or clothing. Physical harm is self-explanatory. It's harm to the child physically. And sexual, again, it's self-explanatory, but there might not be any outward signs, so sometimes a little bit more tricky to determine. Now, if you look at all these children that we can see here, which one of these children is prone to abuse? Just by looking at them. And you might spot the little lad in the corner who's sat with his head between his knees looking really quite sad. We might think it's that child that's prone to abuse. But the actual fact is, it could be any one of these children, rich, poor, young, old. It could be absolutely anybody. But there are some children that are at increased risk. And the younger you are, the more increased risk you are. If you have a disability, the poorer you are, if you're a twin, so the increased stress on the parents, and also an unplanned pregnancy. Now, here's some really important facts, which is that 80% of non-accidental injury fractures are found in less than 18-month-olds. So a fracture in a less than 18-month-old should start ringing those alarm bells, whereas 85% of genuine fractures are actually above the age of 5. Now, here's some really horrible facts that really struck me, and that was that there's between 50 to 100 deaths in the UK because of NAI. And what really concerned me when I was reading all the literature is that 55% of children that die at the hand of non-accidental injury are actually seen by one of us just 1 month before. So we have this window of opportunity to save these children's lives. Now, there's 3 main categories of non-accidental injury, which are physical categories: the brains, the organs, which includes the bones, and also factitious, which is things like poisoning and suffocation. We'll be focusing more on the bone side of it. And fracture is actually the second most common presentation. Soft tissue is the first most common, which is things like bruises. And a third of all kids who have an accidental injury present with a fracture. So actually, in our fracture clinics, these children are coming through. It's up to us to pick up these children, to recognise it and to refer it and to save lives. So history, what are we looking for in the history? What should start raising those alarm bells? Well, these are all the things. Just to pick a few out, it's the inconsistent history. It's a bit vague. No one really can tell you exactly what happened. Again, the mechanism doesn't really fit. They say that they tripped over and yet have all these fractures. We've already talked about the delayed presentations that are taking too long to present. Or maybe they just keep coming to ED. So lots of presentations for accident emergency departments to start again ringing alarm bells. Too many little injuries. So when we're examining the child, there are certain types of fractures that start just ring alarm bells as well. Things like metaphyseal fractures we'll come to, fractures that are on both sides of the body, different ages of fractures, and also skull fractures. They've got a real high specificity. The locations, the ribs, the scapulars, the very ends of the clavicles, the back, and also the fingers and toes. These again should start raising alarm bells. Now, other fractures such as long bone, simple skull, and midclavicular, in the midline of the clavicle, they do present as NAI, but they've got a much lower specificity. So like we said, the skull, the ribs, the humerus, the femur, these are the ones that we should be wondering, is there something else going on here? But like anything, there are other causes for fractures in children that are unexplained. Accidental injury, so they actually did have a fall. Things like osteogenesis imperfecta, leukemia, metabolic disorders like CAFE syndrome, osteomyelitis, infections, and also, unfortunately, neoplasia. So when we see these children and we're worried, let's do investigations, get a full blood count, check they don't have a leukemia. Bone profiles, particularly in the UK, we don't have much sunshine, unfortunately. You can see that I'm quite pale, and that vitamin D, they just don't get it. So they get a bone deficiency because of that. And also skin biopsies are quite important. So talk to your local paediatrician, talk about, should we be doing a skin biopsy for osteogenesis imperfecta? Now, there are other reasons why we get fractures, as I've already said. The subtle sign to look out for is something called periosteal reaction, and it's not an actual fracture as such, but if you grab a bone in a very young child very hard, you can cause a periosteal reaction. But that's a little bit different from a physiological periosteal reaction of a newborn, which is symmetrical. It's usually between 6 weeks to 6 months. Now, this is an example of periosteal reaction where someone's grabbed this bone really hard, causing widespread florid periosteal reaction. You see that on an X-ray, start to wonder. Metaphyseal corner fractures, this is because of a shearing force where a limb is grabbed and twisted. And you get these little flakes at the end of the bone, at the very edge. And if you see one of these are almost pathognomonic. Here's an example of one. They're quite hard to spot, very easily missed. And if you're not sure, leave it a week or two and re-X-ray. It becomes far more apparent at that point. So this is the benefit of re-X-raying children when you're just not sure, safety netting them, bringing them back to clinic. Also, any other long bone fractures, as we've already discussed, particularly as lateral clavicle fractures. But there are, unfortunately, other body signs that we all should be looking out for. It's not all about the bones. And there are some shocking images coming up, so apologies for that. I don't mean to upset anyone at this time of night, but Equally, you know, these are things to have in the back of our minds. So any cuts, bruises on the back, not a normal sign. Subtle bruising in the pinna of the ear or at the back of the neck. Obviously, ecchymosis around the eyes. If you're concerned, do look in the child's mouth. You can get tears of the frenulum in the mouth. Bruising on the insides of the arms and the insides of the legs or over the bottoms, and also burns. These are all the wee signs that you should be looking out for. So what do you do next? Well, after you've admitted them, we do need to speak to the paediatrician and get a skeletal survey. Okay, and the skeletal survey is very useful. It's 17 films in total. We should also consider doing a CT head, and it's really important for documentation. And these are all the bones that we x-ray during that skeletal survey. Now, in all of this, most importantly, we're picking up these signs of these children. We're helping to save this child from any further abuse. But another important role that you have as a clinician is to ensure that you document a really good story. Make sure the time, the date, the author, and the grade of who is seeing that child is documented well, because this will be needed in the courts. Now, with electronic documentation these days, a lot of that is done for you. But the rest of this is important too. Be factual. Be really specific about what you're writing. Be objective. Don't bring in any subjective feelings towards the rest of the family. Don't abbreviate anything, so write everything out in full, okay? And don't speculate. So by that, don't say, oh, this could have been caused by X, Y, and Z. Just write exactly what you've been told. Now, most importantly, and the biggest take-home message from this lecture is act on your gut feeling. If you think something is not right, most likely something is not right. And this child you may be literally their only hope of staying alive. So everyone, please stay alert. So thank you very much for taking any questions. Thanks from the UK.
Thank you so much, Ms. Bucknail, for this very marvelous and interesting talk. Dr. Ahmed Sheikh, Mr. Ahmed is the moderator with Ms. Bucknail.
Yeah, thanks so much, Mr. Bucknail, for such interesting. I think we needed this lecture to increase awareness in Egypt. We haven't got such well-developed social service. We sometimes struggle when you get similar situation. We get the police in the middle, and the police may not be able to deal with this. It needs some dedicated person. So still developing, but it's not that acting properly. So it's very important for our colleagues here, my dear colleagues in Egypt, to be aware of such concerns. And it's all just red alerts. So when you see any of these injuries, follow what Ms. Bucknail told us. And I think this would be the best thing for this kid to be saved. I can't see any questions from our audience. I think you have put the story very clear with some examples, and you told us exactly what we should do. So we might get some questions, and then we'll return back. If you're happy, we can go for the next speaker.
Absolutely. Thank you so much for your time. Thank you.
Thank you so much, Ms. Bucknail. Now we will move